Hello, welcome to Doc Talk Live. This is Dr. Brad Goodman, and it's been a little while since I've been on Doc Talk Live with y'all. This morning I'm with Nick Dionne-Odom. Nick, welcome. Thank you for coming on. We've had a hard time connecting over the last 6 weeks or so. A lot of stuff going on, but Nick is an assistant professor at UAB in the School of Nursing. And he is the co-director of caregiver and bereavement support services at the UAB Center for Palliative and Supportive Care. Welcome, Nick. Thanks for being here.
Yeah, thanks for having me.
Oh, great. So let's just jump right into caregiver support. With COVID-19 going on, that must be incredibly challenging. So my impression is, because I don't directly take care of patients with COVID disease or COVID-19, I can imagine that a patient who is on a ventilator and is struggling for their life with COVID may actually die, that even the family, their close family, can't really get in to be with them toward their end of life. So I'm curious how that works. If you could sort of give me a scenario maybe where a patient's in an intensive care unit with COVID, and can the family see them? How do you work with the family in that scenario?
Yeah, so as we look across the country, what most hospitals and institutions are doing are they're having to impose very strict visiting restrictions for patients who have COVID-19, who are critically ill in the intensive care unit, in an effort to try and contain the spread of the virus itself. And so because of that, families are not typically able to see their loved ones if they're critically in the ICU, and that is unique to this era that we're seeing since March or earlier this year. What that does for families, it can be remarkably challenging on so many levels if they're not able to be with these folks when they're critically ill and potentially dying, and who often do die, as these families have often been providing support for potentially months to years up to that point to begin with. And now they're actually disconnected during a time that's a particularly vulnerable time for this patient who's now very sick, and they can't be with them. They can't offer the kinds of emotional and psychological support. And there's even been,
Your task is really to connect these people, correct?
Yeah, I mean, the task of the caregiver and bereavement support service is a little bit different than what's actively being done to institute these policies and measures. So the CBS service that I co-direct provides consultation and assistance to departments and service lines about how to implement caregiving distress screening and support into their normal clinic flow. And we've had pretty limited involvement with the support of families in these contexts, because really it's been a scramble just to get policies instituted to contain the virus itself. And the person power within the hospital has been so thinned out and strained that the idea of trying to expand services almost to extent to now further include family is a little bit beyond really the capacity, I believe, of most workforces to be able to provide in their institutions. I know that a lot of institutions are working very hard to provide video chatting and simple communication by telephone to patients who are in the ICU, and they're working hard to try and provide updates. But ultimately, the physical distancing that's necessary at this time in that critical care environment is really preventing families from being there with patients when they're critically ill and dying.
So how has COVID directly affected your job or what you do with caregiver support?
Yeah, so a lot of the support that we deliver is via telehealth. So to be quite honest, we're still able to operate by providing caregivers with psychosocial support and skills-based training in our different programs that we've always typically done over the telephone, albeit we've typically had some in-person contact to try and build a relationship up front. But in general, we've still found families to be very receptive to the kind of supportive care services that we are able to provide over the phone. And again, I would say that
What are some examples of those services, Nick?
yeah, so a couple of our programs, they're mostly within a research context, but for those who enroll, we're able to do at minimum distress screening, where we ask caregivers simply on a scale of 0 to 10 what their distress level is, and then based on that score, we ask them amongst sort of a very lengthy-ish list of different problems they might have, what's sort of bothering them, and if there's a particular problem they'd like assistance with. And if that's true, then we have nurses and social workers who can provide either education or sort of a very soft referral to an internal entity within the hospital, like social work or financial counseling, or a soft referral to an external agency, like transportation assistance or durable medical equipment assistance. And they can also, that person, that social worker or nurse can also provide, emotional support and some simple information provision.
So if I'm inferring correctly, some common distressors for a family member caring for a loved one maybe how to provide, let's say, transportation to and from the hospital for chemotherapy or radiation therapy or various tests. It could be getting the appropriate equipment, wheelchairs, walkers, things like that, or even getting the equipment into a car or adaptive things like that. So am I correct? Am I making the right conclusions here?
I would say that the most endorsed category where folks want assistance with is actually managing the patient's symptoms and medications. And so, for example, in our neuro-oncology program, it's called Family Strong. The number one issue that we hear often about is, how do I deal with a seizure that happens at home? And our social workers and nurses are able to provide very simple education about sort of what to look for and what do you do and who do you call when this situation arises. And so a lot of the issues that distress caregivers have to do with the patient's actual illness, cancer condition or illness condition and their medications. Now, some of those other things that I listed are sort of more logistical in nature, arranging transportation, coordinating appointments, coordinating outside services to provide in-home support, things like that. That's sort of another category. Another category is sort of skills and education about managing the patient's health condition. Another area relates to their spirituality and faith. If folks are struggling in that area, we have another sort of area of issues that relate to the emotional impact that it's had on a person, whether it's sort of feeling anxious or feeling depressed or feeling sad or feeling angry. And we also have sort of a list for those different things that can cause people a lot of distress. And then we have sort of social issues, sort of working with other family members, working with the healthcare team, tensions that arise from trying to coordinate your various social networks to try and help take care of this person's day-to-day health. Just a variety of different areas that can cause people distress.
How do people reach you, Nick? Should people be seeing this later and they have, let's say, caregiver issues? which would be a good idea just to write them down in the comments later. But how do people reach you?
Yeah, so our service is actually pretty proactive. The way that what we've learned is that most family members hesitate to reach out for services, either because they don't know that such things are out there and exist, or because they don't really see the need to go get them. So we've developed our service line to actually go and proactively get and reach out as the first point of contact out to families who feel like they're in need of assistance. And so we've worked within departments within our health system at UAB. So we don't actually have a mechanism at the moment for families to reach out to our service so that we can provide some sort of community-based support, for example, like folks who are watching this right now. We want to get there. We just simply haven't developed the business model within the health system to sustain this type of service in a way where it can be that robust. And so where we're working now is within hospital departments and service lines to try and sort of build out and eventually reach the community. I would say that for folks who do feel like they need support who are watching this, there are literally thousands of resources that are available to you that you can find online. And I'm happy to, if anyone wants to reach out to me, I can quickly shoot, easy information, websites, and everything, online support groups that might be be helpful to folks who feel like they could use that.
So Nick, you're aware of the Doc Talk Live page, and you can get on it and see our interview 3 days from now or whatever. Should somebody?
Okay.
Yeah, are you aware of that, or
I'm not aware.
I can help you get there. But
no, I'm not aware. But
I can imagine people will send in the comments, say, "Hey, Nick, this is the situation. Please offer, whatever support you can or resources that may be helpful." So after this is over, hopefully I'll help you find that page. Okay.
Yeah, no, that sounds great. Happy to.
Perfect. Before we finish up, you mentioned to me before we started, we weren't live when we talked about it, but you have some clinical trials going on. Can you just briefly tell us about that?
Sure. So currently we have 2 active clinical trials where we recruit family members to test and see if some supportive care programs can be helpful to them in terms of building their skills, improving their quality of life, and reducing their distress, and then seeing if that actually has a positive benefit to their loved ones that they take care of. One of them is testing, we use community health workers to partner with caregivers who are African American or who live in a rural area, and they coach them on things like stress management and managing and monitoring symptoms, managing medications, and then we teach them some simple skills in communication and how to have conversations with their loved ones about the future and advanced care planning. And the other trial, it's a little bit more targeted. We teach caregivers how to be a good source of decision support to patients when one is diagnosed with cancer. For any of you listening who've experienced this, there are a lot of decisions that one has to make, both treatment related and that kind of reverberate out into other spheres of life. And we have an intervention where we're teaching caregivers how to be better at partnering with patients to help them in that decision-making process. So we teach skills in communication and being a good source of social support, and then how to use different decision aids or tools to help make decisions, say, about treatments that are offered to them in their cancer trajectory. So those are the 2 main trials that we have going right now, and nationally there are trials going on everywhere that are trying to develop better caregiver support.
Perfect. Nick, I want to thank you for taking the time to talk to us about palliative and caregiver support, and I really appreciate it.
Yeah, thank you for having me. Really appreciate it.
Okay. So when I hit stop, we'll talk a little bit about Facebook and Doc Talk Live, so
definitely.
you can find it.
That sounds great.
Thank you so much. Appreciate it.
Yeah.